Good evening. Welcome to the SEME pre-conference SEME on hypothyroidism in infants and children by Dr. Barakat. I will start by introducing Dr. Barakat Fantaun. She had her undergraduate in Gondar College of Medicine, her medical doctorate, and she has her specialization in pediatrics and child health at Addis Ababa University. And her fellowship was in pediatric endocrinology at the British Children's Hospital, Kenya. And she is also a fellow of International Society for Quality in Healthcare. She is associate professor in pediatrics endocrinology at St. Paul Millennium Medical College, and she is currently the outpatient department director at St. Paul Millennium Medical College, and she has worked at various positions, and she has received several awards by her colleagues and institutions and her students, and she's very liked by her patients and her students. She has published more than 21 peer-reviewed journals. So it is my honor to invite Dr. Barakat to present about hypothyroidism in infants and children.
Thank you very much, Dr. Swagan, for the generous introduction. And good evening, everyone. Today, I will present hypothyroidism in infants and children, because hypothyroidism is one of the preventable cause of mental retardation, and diagnosing early and treatment will prevent a child from having serious mental retardation. So before I go into hypothyroidism, let me start by saying a few words about thyroid gland fetal development. Thyroid hormones are needed in fetal life for the development of fetal neurons and brain. So during the fetal life, the fetus will get the thyroid hormones mainly from the mother. And these thyroid hormones are very much important for the brain development of the fetus. When we see the gland, it's one of the endocrine organ to develop early, and its development starts at the gestational week of 3 to 4 weeks, and it starts from the pharyngeal floor, and finally it will situated at its final place at the gestational week of 7. And at 10 weeks of gestational age, that when we see the thyroid gland, it weighs 80 milligram, and at term, it will reach like 1 to 1.5 gram measurement. And for as we all know, thyroid gland is very much important, and the main function of the thyroid gland is mainly to produce 2 important hormones, the T3 and T4. But for this thing to happen, there's the TSH stimulation is very much important. So TSH is mainly, usually, TSH is produced from the anterior pituitary gland, and the TSH secreted in the first trimester of fetal life, and thyroxine secretion starts in the second trimester of life. But thyroid hormones can be detected in the thyroid gland in a small amount at the gestational week of 9, and it will progressively increase to be to the maximum level at term. And the synthesis starting from iodine trapping and production of the thyroid hormones and the release of the thyroid hormone from the thyroid gland, mainly facilitated by the TSH, which is produced from the anterior pituitary gland. So in this picture, we can see the hormones, the TSH, the free T3 and the T3 and the T4 level at a different gestational age and even postnatal. So as you can see, during the late pregnancy, there is a surge of TSH, and the surge of free T4. So this can be also seen in few days after the postnatal period. So until this TSH as well as the T4 reach to the normal level, it's not recommended to do the newborn screening. So the newborn screening, this has a relevance when we talk about newborn screening, and it has to be just at the age of like between 5 to 7 days. Otherwise, if you just do it in the day one, probably you might think that it has high TSH, while it's just a normal physiology. It will happen for every child who is just normally developed. And when we see it from the maternal side, maternal TSH doesn't normally cross the placenta, but T4 and T3 cross in limited amount. But in case of Graves' disease, where the mother has usually thyroid stimulating antibodies as well as thyroid receptor blocking antibodies, these antibodies can pass through the placenta and it can affect the fetal thyroid gland. It can result either in hyperthyroidism or hypothyroidism, or the child or the newborn might be born as a euthyroid with a euthyroid level. So knowing these things are very much important, especially for diagnosis of different conditions, especially when we are dealing with mothers who has a Graves' disease. And another thing in this line is the use of antithyroidal drugs, including P2 and metimazole. It can freely pass through the placenta. So if the baby is born from a mother who is just a Graves' disease, both the thyroid receptor antibodies, the blocking as well as the stimulating antibodies, and the antithyroidal drugs can pass through the placenta, and it can affect the fetus. It can result in just with the balance between the antibodies, the types of antibodies, as well as the drug amount which passes through the placenta, the child might end up either with neonatal Graves' disease with hyperthyroidism, or the child might have just euthyroid, which might need also follow-up for a couple of days and weeks, or the child might end up with hypothyroidism. So knowing all those stuffs is very much important just to interpret and to continue when we are just dealing with a mother who has a thyroid abnormality. So as I said earlier, the main function of thyroid gland is just synthesizing T4 and T3. And the thyroid tissue has a great affinity for iodine, and the iodine will be more than 80% of the iodine which is available in the body will be trapped, transported, and concentrated in the follicular lumen for the synthesis of thyroid hormone. And the process is facilitated mainly starting from the iodine trap, as well as all the other processes will be facilitated by TSH. And most of the thyroid hormone in the blood is T4. Once the thyroid synthesize the thyroid hormones, it will be released to the blood. And when we see the amount, majority of the thyroid hormones constitute T4. And in the gland, the thyroid gland will produce around 80% the T4, in the concentration of T4, and only 20% of the thyroid hormone is T3. But T3 is said to be the active form of thyroid hormone. So peripherally, the T4 should be converted to T3 in order to have adequate amount of T3 in the body, which is the main active hormone which will affect the body. So the transfer or the conversion will be facilitated by the enzyme, which is available in the liver, in the kidney, and in some of the tissues. And but there are certain conditions which might affect this, which might inactivate the dehydrogenase enzyme, especially if the child is very sick child and in ICU, dehydrogenase enzyme might be inactivated, so the child might end up with having signs and symptoms of hypothyroidism, which later on result in increased TSH. So we might, it might be needed just to wait until the child become okay before determination of the thyroid function test, because the enzyme can be affected during serious illness. So when we see the hypothalamus pituitary thyroid axis, TRH, thyroid receptor hormone will be, releasing hormone will be produced from the hypothalamus, usually at the gestational week of 6 to 8 weeks of gestation. Then it will stimulate the anterior pituitary gland to produce TSH, and the TSH will stimulate the formation of, starting from the iodine trapping synthesis, as well as the release of thyroid hormones. And once the thyroid hormones are released, if the thyroid hormones are increased, there will be a negative feedback mechanism by which it will decrease the production and the release of TSH as well as TRH. And on the other side, whenever there is low level of T3 and T4, there will be a positive feedback, and TSH will be increased, and TRH will be also increased, and it will facilitate the TSH will finally facilitate to produce T4 and T3. This process might result in hypertrophy of the thyroid gland and end up with thyroid gland goiter. So this is just the process from starting from iodine trapping, and there is a oxidation process with the help of thyroid peroxidase. It will be the iodine will be oxidized. Then with the help of TSH, it will bind with thyroglobulin protein and tyrosine, and this will result in formation of monoiodothyronine, diiodothyronine, and the combination of these two molecules will produce T3, and 2 molecules of diiodothyronine will produce T4. Then with the help of TSH, again, it will go to the follicular cells, and finally, with the process of proteolysis, it will be released. Once in the blood, in the peripheral tissue, because 80% of the thyroid hormones constitute T4, and only 20% production will be in the thyroid gland. The T3 production will be in the thyroid gland. The remaining comes from the peripheral conversion of T4 with the help of the iodinase enzyme, which is mainly available in the liver, kidney, and in some other tissues. So as I said earlier, when we see, because there will be a surge of TSH and T4 in the late third late gestational age, you can see like the T4 is very high and TSH is very high. So newborn screening, usually it's recommended to do the newborn screening after 4 weeks. And the base setup in the Westerns, usually they will do at the 4th day postnatal age, but in our setup, it's quite recommended to not to be in confusion. It's always good to just to do between 6 and 7 days of postnatal age, because both the TSH as well as the T4 will come to the normal level. So there will not be any confusion. If you do it like in the first day, you can see like the TSH is around 60, 65, nearly 70. So there will be a misinterpretation or mislabeling of a child with hypothyroidism. So when we see the effect of thyroid hormones, in the growth, thyroid hormones are necessary for normal somatic growth. In the development, it's very much important for brain maturation, development, and function. And in the metabolism, it will facilitate metabolic activity and usually increase basal metabolic rate. and it can also affect the carbohydrate, the protein, the lipid metabolism. So, and on the systems, in the cardiovascular system, it increases the heart rate, the cardiac output, and on the CNS, it promotes mental activity, and on the GIT, it increases GI motility. So whenever there is hypothyroidism or hyperthyroidism, whenever the thyroid hormones are low or excess, it will affect all those stuffs. So the growth definitely will be affected. Whenever there is hypothyroidism, the development will be seriously affected. And hypothyroidism is said to be one of the most common preventable mental retardation. And metabolism also will be affected, and the carbohydrate, protein, lipid metabolism will be affected. Yeah, so knowing the effect of thyroid hormone is very much important in order not to miss the manifestation of hypothyroidism when we get a child or an infant who is suffering from thyroid disorders, mainly hypothyroidism. So coming to hypothyroidism, from the definition, it's just hypothyroidism is a result from deficiency of production of thyroid hormone or a defect in thyroid hormone receptor activity. And the deficiency might be why someone or the child become deficient. We'll talk about it later on. And as I said, now and then, it's the commonest cause of preventable mental retardation throughout the world. So one of preventable, because once you diagnose, the management is so simple. Just thyroxine replacement is the management. So not to miss this disorder is very much important. So generally, hypothyroidism can be classified as congenital or acquired hypothyroidism. When we say congenital, the problem starts from birth. When we say acquired, it just comes later on. Or it can be also classified based on the underlying problem. It can be classified as primary or central hypothyroidism. When we say primary, the problem is at the primary gland, that's the thyroid gland. It can be many conditions which can result in primary. When we talk about central hypothyroidism, the problem is either at the pituitary or at the hypothalamus level. So coming to congenital hypothyroidism, when we see the incidence, it can range from 1 in 1,700 to 1 in 3,500 live births. The incidence is partly dependent on the screening strategy. In places where they have newborn screening protocol or newborn screening program, the incidence is relatively high. And in a place where we may not be able to know the incidence of congenital hypothyroidism in our settings. Sorry. So congenital hypothyroidism can be defined as a viable dysfunction of the hypothalamic pituitary thyroid axis. It can present at birth, resulting in insufficient thyroid hormone production. And with that, the child or the newborn will have mild to severe thyroid hormone deficiency, depending on the underlying problem which causes hypothyroidism in that particular newborn. So congenital hypothyroidism may be caused by abnormal development or function of the thyroid gland itself. When we say abnormal development or function, it can be anatomical abnormality in case of like agenesis or hypoplasia of the thyroid gland, or it can be functional abnormality. As we saw it in that diagram, it might be just the problem might be just starting from iodine trapping, organification, oxidification, and the synthesis as well as the release of the thyroid hormone. We call it dysharmogenesis. This is a functional abnormality of the thyroid gland. So these two conditions are, if there's an anatomical problem or functional problem, the origin is the thyroid gland, so we call it a primary hypothyroidism. Or it can be the hypothalamus and the pituitary, we call it central. There are a number of causes of central hypothyroidism. If you take like congenital hypopituitarism, one of the pituitary hormone is TSH. So if that's the case, the child will have low TSH and low, if there is low TSH, definitely thyroid hormone synthesis will be affected. So the child will have low TSH as well as low thyroid hormone. We call it central. But rarely it can be impaired thyroid hormone action because of receptor abnormality at peripheral level. And most congenital cases are sporadic, but in 10 to 20% of the cases, the congenital hypothyroidism might be inherited or it runs in the family. So just coming to the common cause of congenital hypothyroidism, first and the commonest one is thyroid dysgenesis. It occurs in 50 to 60% of the cases. So it can result in hypoplasia and aplasia or an ectopic gland. When the thyroid gland is migrating from the pharyngeal floor to its final place, there might be a problem. It might be trapped somewhere. So in that case, the child or the newborn will have ectopic gland, and they can come to you with some signs of respiratory obstruction during the neonatal period. And ectopic gland is said to be the most common cause from this category. So the cause is usually unknown, this thyroid dysgenesis, but in about 2 to 5% of the cases, it can be inherited. The second common cause of congenital hypothyroidism is dyshomogenesis. This is just functional abnormality of the thyroid gland. The thyroid gland anatomically is located in the thyroid gland place, the anterior neck area, but there is a problem with the thyroid hormone synthesis, and it can result in thyroid hormone deficiencies. What differentiates from the thyroid dysgenesis is because the anatomical gland is okay, and the problem is on the thyroid hormone synthesis, there will be TSH surge, and the TSH will continuously stimulate the thyroid gland, and it will end up with goiter. Goiter is almost always present in case of dyshomogenesis. So if you get a child who has just goiter at a neonatal period, one of the differential diagnoses which should be considered is dyshomogenesis. I had like 2 patients just long time ago, I think it might be just more than 10 years, when I was working at Blackline. There were like, and it runs in the family. It's an autosomal recessive disorder, and it runs in the family. And the mother had just 2 siblings, and one of the first child, she was diagnosed at the age of 2 years, and she has severe mental retardation because she was like diagnosed when she came for like the child with a developmental issue. The child was not able to stand, the child was not able to support herself. So the mother brought the child to Blackline Hospital, and during that time she was diagnosed with hypothyroidism, though dyshomogenesis was not considered, but she was diagnosed and L-thyroxine was started. But she was not counseled. Later on, she had another child, and she brought the child because the child was not able to sit without support and to crawl, and she brought the child when the child was a 10 months old child. And I saw the child, and the child had goiter, a huge goiter, with the thyroid function test severely affected. TSH was very high. It was, I think, more than 100. And the T3 and T4 level was very low. So L-thyroxine was started. The issue is if you don't get them early, they will have severe mental retardation. So the third one is maternal iodine deficiency, especially in our country where there is serious or severe iodine deficiency, especially for those who are just living in the mountainous area in the northern part of Ethiopia. goiter is endemic. So if the mother has endemic goiter, the child definitely will come to you with hypothyroidism and goiter, which will be there at the time of birth. It really can cause congenital hypothyroidism in the USA, but commonly in countries where iodine is not routinely added to the table salt. So I will talk about iodine deficiency later on, but iodine deficiency is also one of the cause, especially in just developing a country where routine utilization of iodized salt is not there. So it will result in, because for the thyroid hormone synthesis, iodine is the adequate amount of iodine is very much important. And the fourth one is ingestion of goitrogenous substance by the mother during pregnancy. It usually results in transient form of hypothyroidism, like cassava, some of the cabbage. It can result in, these are just goitrogenous substance, it can result in hypothyroidism in the newborn. And fifth one is transplacental transfer of antibodies in case of Graves' disease. In Graves' disease, as well as in Hashimoto thyroiditis, there are antibodies, and the antibodies might be stimulating thyroid receptor stimulating or thyroid receptor blocking antibodies. So it can pass through the placenta, and it can affect the thyroid gland of the fetus. So if both antibodies might be there in both cases, Graves' disease and Hashimoto thyroiditis, what matters is which one is predominant. So in case of Graves' disease, the usual scenario is they will have thyroid receptor stimulating antibodies will be in a higher amount, but they can have also thyroid receptor blocking antibodies, and it can pass through the placenta, and it can affect, it can just block the thyroid gland, so that the thyroid gland, the fetal thyroid gland, may not be able to produce thyroid hormones. And the other one is antithyroid drugs, as I said earlier. P2 metimazole can cause transient hypothyroidism. And the other one is the rare form, hypothalamus and pituitary defect. It can be like brain malformation or anything which might result in hypopituitarism. It can result in central hypopituitarism, central hypothyroidism, which might be noticed at time of birth. And the last one, and a very rare one, is thyroid hormone unresponsiveness. This one is a very rare abnormality. And children with trisomy 21, like Down syndrome, they have increased risk of congenital hypothyroidism. So we need to screen them early. How do they manifest? Children with congenital hypothyroidism, at birth, they might be asymptomatic, because during the fetal period, the fetus mainly depend on the thyroid hormone, which is transferred from the mother. So they might be asymptomatic even if the child or the newborn has agenesis. That's the reason why we need to have thyroid newborn screening, because they may not have any symptom. But luckily, patients will have one or like few manifestation of hypothyroidism, and these are like prolonged physiological jaundice, delayed passage of meconium, and stool. These are the prominent features during the newborn periods, if they are just symptomatic, or they can have also umbilical hernia. So if we need to advocate to have newborn screening in the country, but until that, at least for a newborn who has just prolonged physiological jaundice and delayed meconium passage and umbilical hernia, if the child has like one of these manifestations, or hypothermia, it's also one cause for hypothermia, and bradycardia. So in that case, like, I strongly recommend to screen them for possible congenital hypothyroidism. because majority of patients, when they come with a referral, they usually have one of these manifestations, either prolonged jaundice or meconium passage and subsequent constipation. And it's not unusual to see like newborns who has severe constipation misdiagnosed as having Hirschsprung disease. And like, I remember there were like 2 patients, I think it was also like 9 or 10 years ago at Kurambesa. They were, both of them were admitted to C7. One of the child was a 6-year-old child, and the other one is D7, I think. That was a surgical ward. And the other one is a 4-year-old child. And they had just colostomy during the neonatal period, because it was like for the severe constipation, Hirschsprung disease was considered. So they did the colostomy, and they were just admitted for colostomy closure. But that they had severe mental retardation, which cannot be reversed. So we need to be very cautious when we get a child who had just jaundice, delayed meconium passage, as well as prolonged constipation. So when we see them, affected infants cry little, sleep much, have poor appetite, and are generally sluggish. The abdomen is large, the constipation, and they usually have umbilical hernia. The temperature is subnormal. They can have edema of the genitalia and extremity. And goiter in units can be there if there is like endemic goiter of the mother, or if the child has, the newborn has dysorogenesis, they might present with goiter during the neonatal period. So as you can see the jaundice, and you can see also the umbilical hernia, as well as the edema on the extremity. So when we talk about, when we see like how to differentiate primary from central hypothyroidism, the hallmark of primary hypothyroidism, whenever there is the problem is at the thyroid gland, serum T4 will be low if it's not compensated, and the TSH will be elevated. The hallmark of central hypothyroidism, like serum T4 as well as TSH levels, will be low. We need to be very, very cautious. Like if you get a child who has just hypothyroidism and in whom you consider the possibility of central hypothyroidism, don't rush to start thyroid before you investigate a child for possible other pituitary hormone deficiency, especially for STH. So if the child, usually in case of hypopituitarism, the child might have just single hormonal abnormality or deficiency, or they can have 2 or 3 deficiencies. So if you start them on L-thyroxine before you start them on cortisone, the child might end up in adrenal crisis. So if you get a child who has just possibility of central hypothyroidism, do cortisol level and as well as STH level. If the cortisol is found to be low with the STH also low, you need to start them with cortisol for a couple of weeks. Usually the recommendation is for like 10 days to 2 weeks. Then you can start on L-thyroxine. If you don't do that, the child will end up in adrenal crisis, because if any child who has hypothyroidism, their metabolic rate is severely affected. And in that time, if the child has low cortisol level, it might be okay for that low metabolic rate. But by the time when you start them on L-thyroxine, just the metabolic rate will be increased. So the demand of cortisol will be increased. And if the body is not able to produce the required or the needed amount of cortisol, definitely you will create a kind of crisis, adrenal crisis. So it's always good to categorize whether the child is having hypothyroidism because of the central origin or primarily because of the thyroid gland. So we always recommend to have TSH without getting TSH. If you get like all the symptoms of hypothyroidism and only the result of free T4, don't start on thyroxine. One is that. The other one is just we'll follow them. The response will be like we'll follow the TSH level as well as the free T4 level. So this categorization is very much important before you embark on treatment. So the diagnosis of congenital hypothyroidism in the base setup is through neonatal screening. Every newborn is just they always do the thyroid function test. In some place, they'll just do the TSH alone. In another place, both free T4 as well as TSH. And in 60% of the cases, those newborns who has congenital hypothyroidism will have delayed born age. That's also one evidence. And another thing, especially if you are just suspecting the possibility of this agenesis, hypoplasia, or ectopic thyroid gland, we can do scintigraphy, radioisotopes scan, where you can see the availability of the thyroid tissue. And if you do ECG, it can result in low cardiac output. So you can see low voltage, low P and T waves with diminished QRS complex due to poor left ventricular function. And isolated pericardial effusion, if you get a child who has just isolated pericardial effusion, one of the things which has to be ruled out is the possibility of hypothyroidism, even in the older children. And how do we treat? Irrespective of the underlying problem. If you get a newborn with hypothyroidism, the treatment is just thyroxine replacement therapy. And it has to be started before the age of 2 weeks because the brain grows very, very fast in the first 3 months of life. So if you miss that, definitely there will not be, if you get a child at the age of 3 months, definitely there will be a mild form of or moderate form of mental retardation. So the recommendation is just right away, immediately after the screening, between the age of 5 to 7 days, you need to start the treatment. The medication is given orally, and it has to be given. Usually the recommendation is in empty stomach, which will facilitate the absorption, and it has to be given regularly, and those shouldn't be missed. Yeah. So don't stop thyroxine when you get normalization of the thyroid function test. What is if you get a normal result, it tells us the thyroxine which is given for that particular child is adequate. So just you will continue. And I think if you have any issue with that, probably you might consult us before. It's not recommended to stop if you get a normal thyroid function test. There are times in which we might consider just discontinuing the thyroxine replacement therapy, but don't do that unless otherwise there is thyroxine toxicity or a sign of hyperthyroidism or significantly lower TSH and high free T4. I think it's always good to just consult us before you decide on discontinuing the thyroxine. Okay. So coming to acquired hypothyroidism, when we see the epidemiology, the commonest cause in pediatric age group, the commonest cause from acquired hypothyroidism is Hashimoto thyroiditis. We call it chronic lymphocytic thyroiditis, and around 1.3% of patients have autoimmune thyroidal disease, and it occurs. Females are affected more than males. And common causes, when we talk about common cause of acquired hypothyroidism, autoimmune disease, like this chronic lymphocytic thyroiditis is the commonest one, followed by iodine deficiency, especially in our scenario. And rarely iatrogenic drugs like antithyroidal drugs for hyperthyroidism, or if the child had neck irradiation or thyroidectomy for like thyroid CA or whatever, it can also cause hypothyroidism. And central hypopituitarism is also beyond the neonatal age group. It can result in acquired form of hypothyroidism, especially craniopharyngioma. Patients with craniopharyngioma, because of the location, it can affect the pituitary gland. And one of the hormones which can be affected is the thyroid hormones. And transient after discontinuation of long-term treatment can result in acquired hypothyroidism. And how do they manifest? Whatever the case, whatever the underlying cause, children usually present with these signs and symptoms: slow growth rate, constipation, cold intolerance, lethargy, delayed dentation, oversleepiness, deterioration in school performance. These are the symptoms commonly seen in a child who has hypothyroidism. And signs like bradycardia, low pulse pressure, dull flaccid expression, short stature, mild overweight, goiter, and delayed bone age, these are all the manifestations of hypothyroidism. Let me tell you one case scenario. There were like twins, girls. They had like the symptoms of hypothyroidism for more than 2 years. They were like, I think their age was 12 to 13 age. So just they had like the symptoms of hypothyroidism. They had just constipation. They were not growing. They were not active. So and the father said like, and he was just complaining about their school performance deterioration. So nobody was considering the possibility of hypothyroidism. And when I get them, like in one of the child, the TSH was above 60, and the other one had the TSH was above 100. And they were, both of them were just chubby, dull face expression in a bracho. And just I started them on L-thyroxine. It's very, nowadays it's a little bit expensive. Otherwise, the cheapest endocrine replacement therapy is L-thyroxine. So just I started them on the L-thyroxine, and all of the features returned back to normal. And they were so beautiful girls. So just we need to suspect and we need to act accordingly. And the treatment is very simple. Once you consider the possibility, even the diagnosis is simple and the interpretation is so simple, and right away you can start them with L-thyroxine. Yeah. So all of these features may return to normal if there is early and appropriate treatment. So we need to diagnose. High index of suspicion is very much needed in this kind of scenario. So I want to say a few points about Hashimoto thyroiditis, which is the commonest form of acquired hypothyroidism in children. So it's just an autoimmune disorder, and it's also called lymphocytic thyroiditis because the thyroid gland is infiltrated by lymphocytes. So in this disorder, just you will get thyroid antiperoxidase antibodies and anti-thyroglobulin antibody in 90% of the cases. So in a setting where we can do like antibodies, it can be diagnosed easily. You can detect the antibodies and you can diagnose Hashimoto thyroiditis. Otherwise, just we need to depend on our own clinical judgment, and it's quite common in adolescents and on those children who has just above 6 years of age. It is the commonest cause of acquired form of hypothyroidism. So most of the affected children are clinically euthyroid and asymptomatic in case of Hashimoto thyroiditis, but some of the patients might present to you with signs of hypothyroidism like fatigue, cold intolerance, weight gain, and at times they can be, and when you do the thyroid function test, they clinically they might be euthyroid, but TSH might be elevated. In that case, just your clinical judgment should be there. Few patients might present with hyperthyroidism. You know that Hashimoto thyroiditis and Graves' disease are a disease spectrum. At times, the individual might have Hashimoto thyroiditis, and in the meantime, they can go into remission phase, and they can have also Graves' disease. So just you need to check their clinical manifestation as well as a thyroid function test, and you will act accordingly. Yeah, and it's also associated with other autoimmune diseases, so you need to check them depending on the symptoms. You have to check them for other possible autoimmune diseases. So how to diagnose Hashimoto thyroiditis? Yeah, of course, we need to depend on the clinical manifestation. They can come to you with goiter, and if they have the hypothyroidism manifestation, they will come to you with fatigue, constipation, growth failure, and the like, delayed puberty, and the like. So you will see that clinical manifestation, and of course, you will do the laboratory investigation and do T4, TSH, and you might get just normal T4 with elevated TSH. So you will do just the treatment, the decision will be on your clinical judgment. And if in a place where thyroid antibodies can be done, like that will be the gold standard to diagnose Hashimoto thyroiditis. Thyroid ultrasonography can be done, and you can see also clear description of Hashimoto thyroiditis on the ultrasound. Yeah. Next slide. So if there is evidence of hypothyroidism, replacement therapy with levothyroxine is required with a dose of 4 micrograms per kg per day. And the goiter, usually if they have goiter, they usually show some decrement in size, but it might persist for years. So if once the thyroid function test has been normalized, even if there is goiter in there, you will just continue with the amount you prescribed earlier on. A large goiter in a euthyroid patient will also regress with suppressive doses of levothyroxine. At times, the thyroid function test might be within the normal range, and the individual is euthyroid, no other manifestation of hypothyroidism, but the child might have huge goiter. In that case, you can order suppressive dose of levothyroxine, and you will follow the patient. And I just want to talk about goiter and iodine deficiency with a subsequent slide. So goiter is an enlargement of the thyroid gland, and persons with enlarged thyroid may have euthyroidism, hypothyroidism, and hyperthyroidism. Goiter is not equivalent to hypothyroidism. So if someone has goiter, they can have a normal thyroid function test. They can come to you with hypothyroidism depending on the underlying cause of goiter. It can be congenital, just like as I said earlier. Dyshomogenesis will result in huge goiter, and if there is from endemic goiter, if the mother has maternal iodine deficiency, severe iodine deficiency, it can result in neonatal goiter, or it can be acquired, like I was talking about Hashimoto thyroiditis, or it can be just sporadic. So it's quite common in our northern part of Ethiopia. When I was in Gondar during my undergraduate study, we were seeing a lot of patients with huge goiter. So those are just on the highlanders. Iodine deficiency is quite common, and with its complication, iodine deficiency with huge goiter. So causes of goiter in children, I already mentioned all those things: maternal iodine deficiency, dyshomogenesis, autoimmune thyroiditis, antithyroidal drugs. Congenital hyperthyroidism can result a child who is just born from having a mother with Graves' disease can have also goiter, and teratoma can also result in goiter. So it needs to be investigated. During a neonatal period, apart from the other hypothyroidism symptom or whatever, they can have also respiratory distress because of the compression of the trachea, because of the anatomical location of the thyroid gland. It can compress and it can result in severe respiratory obstruction. So in that case, partial thyroidectomy might be indicated just to alleviate the obstruction. So just a few points about iodine deficiency. It's as I said earlier, iodine is the main function of iodine in the body is for the synthesis of, so far, it's known for its importance for thyroid hormone synthesis. So the daily requirement in children ranges from 90 microgram to 150 microgram per day. Iodine deficiency causes a larger thyroid and impairs brain development and linear growth delay, and it can result in cretinism. I remember there was one child just that was also many years ago. She was like 11 or 12 years old child, and her height was 84 centimeters. That is the height of a 2-year-old child. She was 11 years and mentally dwarf, and most probably, and she came from Goiter. And we considered the possibility of iodine deficiency results in severe hypothyroidism, and just we advise them to have iodized salt. And of course, she was started on levothyroxine. She just showed a few increments in her height. And prevalence of iodine deficiency, it's most environmental iodine deficiency. Nowadays, just around 2.2 billion world population are affected by iodine deficiency disorder. The deficiency might range from mild to severe deficiency. So it's just a huge a population of the world is affected by iodine deficiency. That might be the reason for why we have several cures in this world we are just living. So, but in a place where fortifying table salt with iodine is a routine practice, we don't see iodine deficiency. So iodine deficiency, iodine supplementation, we need to advocate about iodine supplementation for every individual. How do they manifest? Patients or children with, and any individual with iodine deficiency disorder, they can come to you with goiter, because whenever there is low thyroid hormone, because if there is iodine deficiency, definitely there will not be adequate amount of thyroid hormone in the body, so it can result in increased TSH, and TSH will stimulate the thyroid gland. It will result in huge goiter. So they can come to you with goiter. And of course, the sign and the symptoms of hypothyroidism. If it happens in the mothers, it can affect decreased fertility. And even if they become pregnant, the risk of stillbirth is very high, spontaneous abortion, and it can result in prenatal and infant mortality. So as a strategy, because the infant perinatal mortality and new mortality is high in our country, we need to advocate also iodine supplementation for every individual in this in our country. Severe maternal iodine deficiency retards fetal growth and brain development, sometimes resulting in birth defects, and infants might end up with congenital hypothyroidism, and it can result in like 13.5% IQ loss. So it's a huge effect. So we need to fight for that. So it can result in deaf, mutism, difficulty walking, short stature, and sometimes cretinism. Yeah, so diagnosis of iodine deficiency, the clinical examination, and it's quite common in the certain places, especially the severe form. So you need to take that kind of history and T4 TSH, and if we are able to do the urine iodine level, probably we can do the urine iodine level, and routine newborn screening, especially if the mother is affected by iodine deficiency, it can definitely will affect the newborn. So treatment of iodine deficiency, iodine with or without levothyroxine. So infants with iodine deficiency are given levothyroxine, 3 micrograms per kg orally once a day for a week, plus iodide, 50 to 90 micrograms orally once a day for several weeks to quickly restore a euthyroid state. And children are treated with iodide, like 90 to 120 micrograms once a day, and are given levothyroxine until they are able to synthesize adequate amount of T4. So having said this, just how do you monitor in any case, like if a child comes to you with a possibility of be it congenital or acquired, be it primary or central hypothyroidism? These are just the things which has to be followed. Like clinical symptoms resolution, we need to follow them. Of course, vital signs, especially the heart rate, is very much important. And anthropometry, measurement and interpretation, the length or the height and weight is very much important. And of course, we need to assess their developmental milestones. And serum free T4 and TSH should be checked once you start them on levothyroxine, like especially for the congenital hypothyroidism, just after 2 weeks. Probably for the other forms, you can check after 4 weeks, then just check depending on the result. And once it becomes just normalized, you can follow them every 3 to 4 months. And of course, the message is don't stop thyroxine, because we have seen many patients who has just started and taking adequate amount, and just in the middle, once the test is normalized, someone just discontinued, and they will have all the symptoms will come again. So prognosis, can you hear me?
Yes, Dr. Barakat, we can hear you.
Yes. Prognosis of hypothyroidism, it depends on the early detection and treatment of hypothyroidism in general, specifically congenital hypothyroidism. So newborn, we have to fight for the newborn screening to prevent severe neurodevelopmental delay and optimize the developmental outcome. Delay in diagnosis, inadequate treatment, and poor compliance will result in variable brain damage and growth retardation, as well as a poor school performance. And around 20% of children will have a neurosensory hearing loss, and without treatment, affected infants become profoundly mentally deficit and dwarf. How to prevent hypothyroidism, at least the commonest one, the congenital hypothyroidism, just by early diagnosis and treatment. So in a place where they can do the newborn screening, it can be done just between the age of 5 to 7 days. But in our place, at least we can screen newborns who do have prolonged jaundice, delayed meconium passage, hypothermia, umbilical hernia. It's a must to do the thyroid function test. At least we can. From this presentation, please just take this message. Just do thyroid function test specifically for those who have these symptoms. And for iodine deficiency, community education, just to use iodized salt, that has to be just, we need to educate our community. And for acquired form of hypothyroidism, in any case, high index of suspicion for diagnosis and treatment is very much important. And the take-home message is hypothyroidism is the commonest cause of mental retardation. Early diagnosis and treatment after birth is a must to prevent the severe complications, and don't stop thyroxine. So just thank you very much for your attention and your patience. And then thank you.
Okay. Thank you, Dr. Barakat, for your nice presentation. Yeah, we have like inconveniences. This is beyond our control. So as we have said previously, she has discussed about hypothyroidism in infants and children. I have revised the previous one, maybe about Goiter. She says that Goiter can be congenital, or it can be an acquired one. Also, it can be an endemic or sporadic. And so the important thing that she told us about monitoring of hypothyroidism, especially we have to do, especially in children, one of their parameters is their anthropometry has to be measured. We have to measure the weight, we have to measure the height, so that our treatment is working. So also we have to do developmental assessment. Then she has repeatedly emphasized, please don't stop L-thyroxine, even if the thyroid function is normal after treatment. And also regarding the prevention, she has discussed nicely about the importance of screening, but in our setup, we're not able to do screening. So for those with overt clinical symptoms, especially those with developmental delay and those delayed muconium passage, we have to do thyroid function test so that we can manage these infants on time. That's as discussed. And maybe if you are Dr. Barakat, can you hear me? There are questions.
Yes.
So yeah, some of the questions I have tried. Maybe let me give you some of the questions. One question is, what about those newborns with equivocal result at the first week, but TSH is elevated above 10?
Yeah.
And can we wait? Are you hearing me?
Yeah. Normally, the cutoff point for the cutoff point, like to treat the child as having hypothyroidism, TSH has to be above 8. And for patients with Down syndrome, the cutoff point is just TSH is 10.
I think Dr. Barakat has a connection.
Okay.
Perhaps if Dr. Swaga, you can proceed answering the questions that she has started.
Okay. So regarding the elevation of TSH, so as she discussed previously, in the first weeks of age, the TSH is normal elevated. It's not compared to the older children. So in the first week of age, if the TSH is not significantly elevated, usually we don't take it even 20. So if that's not significantly elevated, we will not consider that as hypothyroidism. But if after weeks of age, if the TSH is above 10, it is abnormal. Okay, it is abnormal, and we have to treat this patient. Even if the TSH is below 10, and the child has clinical symptoms, that means if the TSH is elevated, the child has clinical symptoms compatible with hypothyroidism, then we need to treat about this for this infant. That's the message. Dr. Barakat, are you back?
Yes, I'm back.
Okay. Yeah, and proceed was
yeah. So
I'm sorry to interrupt. If Dr. Barakat, maybe you don't turn on your video and then try to only answer the questions via the audio, and let's see if the connection would be stable enough to keep you in the meeting.
Yeah. So just you will follow them clinically, and if the child is okay, like you can repeat the thyroid function test. Usually the recommendation is just after 4 to 6 weeks, you can repeat the thyroid function test. But if the thyroid function test is persistently in a higher range, probably even if it's not above like 10, you can start them with low dose L-thyroxine, and you can follow the child. Yeah.
Dr. Barakat, what do you say anything about Down syndrome? Do you have any special cutoff point for Down syndrome? And the other question is about the same about the Down syndrome. The question is there dysharmonogenesis common in patients with Down syndrome? That's okay, the question. So you can proceed.
Yeah, with the Down syndrome, the cutoff point is 10. Because you cannot differentiate between, like, some of the manifestation can be because of the Down syndrome as well. So just will depend on the TSH level, but if they're just suffering with constipation, again, we can try with the borderline equivocal result. You can try with a low dose levothyroxine, and you can follow them with clinically as well as with laboratory test. But TSH 10 and above is the cutoff point. Basically, Down syndrome, it's not about associated usually with dyshomogenesis, but usually they will have autoantibodies. And as I have been just discussing with Hashimoto thyroiditis, it's very rare to see Hashimoto thyroiditis below the age of 3 years. But in Down syndrome, they can have autoantibodies, which might affect the thyroid hormone, the thyroid gland, and the synthesis of thyroid hormones. So the presentation can be earlier. So earlier, they can present with hypothyroidism. So whatever the case, whatever the cause for the hypothyroidism, the message is if the child has clear signs of hypothyroidism, go ahead and treat them with L-thyroxine for every child.
Thank you, Dr. Barakat. The other question is the newborn will start doing L-thyroxine 10 to 50 microgram per kg, and thyroid function is normal despite the patient is gaining weight. So what will be our approach? That's the question.
If the thyroid, okay, just we will follow with other parameters. Like one of the parameters is the heart rate, the pulse rate. And the other one is their growth in general, the linear growth. And if the child had symptoms like hypothyroidism symptoms earlier on, those are the things which has to be followed together with the thyroid function test. And we cannot attribute, as far as the thyroid function test is normal, we cannot attribute the weight gain for related with hypothyroidism or with our treatment. That, did you get my point?
Yeah. Yes, we get. And can you go to the next question, Dr. Barakat?
Sure.
Okay, the other question is, how do you approach a child with subclinical hypothyroidism? That's the question.
Yeah, subclinical hypothyroidism, we call subclinical if the individual is not having any clinical manifestation and usually having low normal or normal thyroid, the T4 with a little bit elevated TSH. So you can follow if it happens during the newborn period, you can check the thyroid function test at the age of 3 months. But in the meanwhile, if the child develop any of the symptoms, you can warn the mother, you can tell the possible manifestation of the hypothyroidism. And if there's any, the mother can bring the child earlier and you can start them with L-thyroxine. Otherwise, just you will follow them with the thyroid function repeat test at the age of 3 months, especially for the newborns, and then just you will repeat at the age of 6 months, and you can see. But majority of the patients, they might have elevated TSH in the meantime. So in that case, just this can become symptomatic. In that case, you can go ahead and start them with L-thyroxine. But it should be depending on your clinical judgment. Like if the child is not symptomatic and if the T4 is, they will become symptomatic not because of the elevated TSH. They will become symptomatic when there is low T4 and T3 in the system. So as far as the T4 and the T3 is normal, and as far as the child is not clinically symptomatic, you can just clinically as well as with the laboratory result, you can follow them.
Thank you, Dr. Barakat. Yeah, yes, you said we need to follow them. Maybe that TSH is persistently high, then we may decide. But for the sake of elevation of TSH, it's not recommended to start treatment. That's Dr. Barakat was saying. Maybe the final question is, what are the difference in the approach of thyroid problem hypothyroidism in children as compared to the adults? Is there a different approach in terms of cutoff points of thyroid function test? And that's a question forwarded.
I think the cutoff point, like TSH, if it's just, I don't know, but if TSH is above 6, that's an abnormal test. So for our children, we need to just, the cutoff point is 8, just to initiate the treatment. I don't know, I really don't know whether they just stick to that guideline for adult patients, but by the time when you do this thyroid function test, especially in adult population, majority of them, they're just symptomatic. So they have to be started on thyroxine. Yeah.
Thank you, Dr. Barakat. Yes, clearly we can say about about children and infants. Maybe the adults, we have other people that they can comment. But for us, in the first 2 weeks of age, because the thyroid function test is different. Beyond that, it is almost it is anything the TSH is elevated, then we can treat. But in the first 2 weeks of age, as Dr. Barakat discussed, especially in the first few days, TSH will be high as compared to the older children. That's what we're doing. So I think if I can't see any other questions. So you have nicely presented, Dr. Barakat. Yeah, we know the challenges we are living, but despite this challenge, you have clearly presented about the approach of infant and children with thyroid disease. I really thank you very much, and also the attendance, despite this inconvenience, you have followed us with the patients, and thank you for your active participation. Maybe you have any final point, Dr. Barakat, before we close the session.
Just thank you very much, and don't forget the take-home message. Don't stop L-thyroxine. Early diagnosis and treatment will save the life of the child. Thank you very much for the facilitation.
Thank you again finally I have a communication. So all of the attendants, we invite you for the second annual conference of SEME, which will be conducted on March 7 at Sheraton Addis. There are lectures, exhibitions. So please, we invite you to attend this important second annual conference. So thank you very much for time. Okay, thank you also the Yetena Weg for conducting such a wonderful session. Thank you. My final point, there is an attachment to the chat so that you can fill this Google form so that you can have your same points. Thank you.
Thank you.